Hi, and welcome back to Becca Babbles podcast. I'm your host, Becca. I'm a certified personal trainer, holistic health coach, and future chiropractor on my way to figuring out this thing we called life. Now, let's get babbling. Hi, everyone, and welcome back to Becca Babbles podcast. I have a special episode for you this week and a special guest. We dive into all of my favorite topics, performance, strength, and what it really takes to keep an athlete healthy and pain-free. My special guest is Dr. Blake Graham. He is such an amazing guest. You can definitely tell that he's been in the educational system, but then also been a great clinician as well and researcher, because he's able to understand research, break it down enough to where other people can understand it. And I just love that when it comes to being able to interview a guest on the podcast. Dr. Blake Graham is a sports chiropractor and performance specialist at Delta S Performance in Golden, Colorado. He serves as the president of American Chiropractic Board of Sports Physicians and is the director of performance and sports medicine of the U.S. Fistball Association. I did not know what that was when I first met Dr. Graham. I looked it up. I highly recommend that you look it up because it's kind of like a mixture between volleyball meets soccer meets fists. So that one's a fun one to just like watch videos on. Dr. Graham is known for bridging biomechanics, workload tracking, and data-driven recovery to help athletes move and perform and feel their best. This episode is jam-packed with practical advice, clinical gems, and mindset shifts that you can either take to the clinic if you're a clinician or to the gym yourself if you're just a regular gym goer and want to get better recovery and performance. This is honestly one of those conversations where I walked away and I was rethinking my approach. I remember driving to school and just being like, okay, rethinking about everything he talked about and was like, okay, how can I apply this to the patients that are in front of me? Or how can I apply this to my own gym workouts as well? So if you love rehab and you love performance and strength and evidence-based chiropractic, you're definitely going to love this episode. So make sure you follow, subscribe, and share this episode with anyone you think would be interested in it. And with all that being said, I can't wait to babble with you next time. So since I'm a chiropractic student, I love to hear chiropractor stories on what drew them to chiropractic. So I'm kind of curious, what drew you to this profession?
Yeah, so as a high school student and athlete, I started seeing a chiropractor when I played football in Texas, as one does. And I remember taking a pretty nasty hit my sophomore year that really wrecked my neck. And so my mom had been to chiropractor for a while, somebody that we went to church with, and she took me in, got adjusted, and that just became part of my overall regimen for getting through the football season was getting adjustments, especially on Saturday mornings. That was part of my post game routine was go to the chiropractor Saturday morning, then show up for Saturday workouts. And I will say, with very anecdotal evidence, I was always way more recovered than everybody else when I showed up Saturday morning. So that was already kind of my buy-in for getting into routine chiropractic care. And then coming out of my junior year of high school, our friend who was a chiropractor, he came to our last playoff game where we lost, I think 64-0, which was a whole lot of fun. But my mom had mentioned to him that I needed to find a job now that football season's over, and they were looking for an assistant. So I started working part-time at a chiropractic clinic. And at the time, I actually was very interested in music production. And working at this chiropractic clinic, though, really opened my eyes to what chiropractic was and my interest in healthcare. So that changed my trajectory in high school. And coming out of high school, I knew I wanted to be a chiropractor. So every decision I made in undergrad was all around I'm going to go to chiropractic school. So I'm going to try to speed this process up. And every course that I take needs to push me towards what I wanted to do. So fast forward a little bit, though, is I went to Parker University, and in my clinical experience, that's where I really discovered sports chiropractic. My idea of what a sports chiropractor was pretty limited. I knew that athletes came in and got adjusted. But after I started my clinical internship and met some other true sports chiropractors, that's when I realized, oh, there's a whole lot more to this, and chiropractors are actually being utilized at the highest level at a lot of athletic endeavors. So getting to know some of those players in high performance is what kind of set me on my trajectory once I graduated from chiropractic school. So I immediately started taking courses to get my CCSP certification. And in getting my CCSP, I learned about the diplomate program, and again was all in on that. When I heard that there was a higher level, it's like, well, I gotta achieve that, but also getting to know those sports diplomates, and especially at the time, that was when we had a lot of diplomates working at the U.S. Olympic and Paralympic Training Center, and seeing what they were doing and hearing them talk was just an incredible learning experience of again, there's a lot more to this than just getting somebody on my table, adjusting them, maybe doing some soft tissue. So I was very fortunate that early in my career, I got to experience a lot of people and learn from them, get to shadow, and put me on the path that I'm now on.
That it sounds like you just like took every opportunity that you had and opened more and more doors just to get more and more education, which makes sense because you've had a ton of like unique experiences.
Yeah, it's you don't necessarily want to say yes to everything, but you want to keep your mind open enough to taking certain steps through different doors.
Hmm.
And had I not said yes to one thing, it wouldn't have led to another. And you never know when all that's going to pay off. For example, I was very fortunate to get asked to work the World University Games in Lake Placid in 23. This was still coming out of a lot of COVID protocols, and because this was such a major international event, the state of New York was being very strict on their protocols, and they completely overstaffed this event. So I
Hmm.
was in the main medical center with probably 7 or 8 medical doctors and DOs. We had another PT who was there, and I was the only chiropractor at the main medical. And for 18 days, we pretty much sat around. We really didn't do anything because there was poor communication, again, overstaffing, and so we ended up going on our second week. We backed off a little bit on how we were staffing our clinic, and so we also then tried to fill in at other places when we could because they were so busy and we weren't doing anything. So I literally spent 18 days in Lake Placid twiddling my thumbs, getting to know people, which was really good, but not doing a whole lot. Uh, which was kind of a bummer because we were in the process of selling our house, and so my poor wife is having to handle everything while I'm essentially on vacation, which is not ideal. But in 24, one of those doctors I worked with, he texted me kind of randomly one day and said, "Hey, I'm the medical lead for the for Team USA for the World University Games. We'd love to have you come with us to Italy. It's all expenses paid. You'll be with certain teams." And so it took a good 20 months for that event to pay off, but it did come to fruition. So you don't ever know how something is going to end up paying out in the long run. And it would be really easy for me to look back and say, what a horrible waste of time. It was awful. And that immediate gratification is important. But now I got to experience a whole different element by being part of the uh, our Team USA local team in Italy because of saying yes to that experience in Lake Placid. Uh, so it's important to again keep options open. I think a lot of us can get very narrow minded, especially coming out of school. Is this is exactly what I need to do? This is who I'm going to be, and I'm not going to deviate from this. Which is good to have vision, but it's also important to make sure that you're not so tunnel visioned that you can't take a small deviation because that can open a whole lot of other opportunities and options for you, and it also expands your clinical worldview as well. It's very easy for us in the clinical world to get super focused, and we have to broaden our horizons because you don't know what kind of patients are going to walk into your clinic or the other opportunities you may get and experience when you have various types of patients in front of you.
Yeah. So with that thought process, you said that it's important though to like know when to say yes and know when to say no. So like
Mm-hmm.
for you, what is that determining factor of when you're like, this is an opportunity that I want to go after, or this is an opportunity that I maybe should like wait on or not do?
Yeah, the joke in my circle though is if there is free gear involved, I'm in. That's that. Yeah, if I'm gonna get a free T-shirt,
Yeah.
cool, I'm in. There's a little bit of truth into that, but it is uh, it's about being responsible. So it is important that you do have to take in consideration life and what's going to happen to your patients if you're saying yes to go to an event, um, or as you maybe make other connections from the business world. It what kind of connections do you already have? Is this going to interfere with some of the other uh, opportunities that you're currently pursuing or already have? As I've been starting up this clinic here in Golden, that's kind of the question I've been asking myself is, as I talk to a gym, well, if I go talk to this other gym, are they, will that put me at odds with each other because maybe they don't like each other or there's history there. So you do have to be cautious and cognizant of what does saying yes to this then entail from an internal perspective and your own integrity versus externally, and what do people see, especially on a business side of things. But when it comes to volunteering for games, I'm pretty wide open. That's just how I've always been because I knew this is what I wanted to do. I really enjoyed the travel work. It's hard. It's they're not easy. There was days when I was in Italy, I worked 20 plus hours,
Mm.
uh, but I will do it in a heartbeat. It's very gratifying to help the athletes perform at their best. Uh, I think everybody's level of what their comfort is on saying yes to things is different. So it's also about knowing yourself, but it's also important to know what's going on in your clinic world too. Because if you say yes and volunteer for 2 weeks, do you have patient drop off? Are you maybe lacking on your patient plans because you're taking off? So that all has to be considered. But I do think too many clinicians say, well, my patients, because I'm making a whole lot of money here, and why would I go volunteer my time?
Yeah.
And there's just something about being able to get out of your comfort zone a bit that helps shape your clinical mindset. The amount I've learned from other clinicians at these events too is amazing, especially when I'm working in an interprofessional team and I'm getting to work, hand in hand with an MD that I don't get to do every day. I'm working with a PT, I'm working with an athletic trainer. It's really, really good to also hear different perspectives and experiences when it comes to patient athlete care.
Yeah. It's almost like you're putting yourself in a position of being okay with not being the smartest person in the room to learn from others.
Oh, absolutely. Yes. Yeah. The only time I would say, you're probably the smartest is if you're leading the entire thing. Um,
Hmm.
but even then, that's usually more admin work than it is patient care, which is a whole different learning experience. And
Hmm.
being able to run an event is very different than being a clinician volunteering an event. Uh, there's a lot to it that I don't think many people can appreciate until you've been in those situations of, how do you manage hundreds of athletes at once, and how do you manage uh, different professionals working a single event, and everybody kind of knowing what their role is, what their lane is, and be able to work together too, because a lot of people have preconceived notions on what we're going to do, especially as a chiropractor, and that's even an uphill battle we have in some of those experiences. That I had a little bit of that in Italy. I was paired with an MD who had never really worked with a chiropractor before, and I could see from the very beginning in our introduction, he was already a little bit weary about what I was going to do.
Hmm.
And as we had a few of the hockey players come and get evaluated, he started overhearing what I was saying. And then he came to me and he's like, "Oh, that makes sense what you're doing." And so I kind of explained to him, especially as you heard my osteoarthritis talk and talking about cytokines and inflammation. Once I started using those terms, he was bought in. And if anybody had an MSK issue, he was sending them right to me. So we had a pretty good buy-in, because I also didn't come in and say, "Well, I'm in charge. I'm the MSK expert. You're the MD. You do this." We we can have a tendency to come in and want to be the smartest person in the room. Instead, let's all come in humble with one another and serve the athletes.
No, that's a great perspective to have, is just like instead of just telling, just showing. And I know there was an opportunity where you started working at Parker University as a teacher in the clinic. How did moving from the clinician side to more of a teaching role change or enhance your clinical skills moving forward?
It definitely made me pause and think a whole lot more about what I was doing, which is probably a good thing. And I started my teaching career. Really, it started when I was a student at Parker. I was a teaching assistant in gross anatomy, which was very very insightful for what I ended up doing with a whole lot of soft tissue work. Being in the gross anatomy lab for 2 years, getting to see all that, but leading tutoring sessions and test preparation, I had to make sure I knew what I was talking about when I was tutoring. So it was almost more of putting me back in the student seat, which was really good. And I'm a big believer in lifetime learning. But in practice, I then actually went back and started teaching anatomy and physiology again at a local state university. So I became an adjunct professor at a university teaching A&P, and that's where probably my reignition for teaching came back. And that was right during the beginnings of COVID as well. So I taught for a year pre-COVID, and then was teaching during COVID as well. And with my clinic at the time, that's where I kind of did a reevaluation of my priorities. And at that time, I just really enjoyed being with students a whole lot more, and wanted to kind of get out of the clinic space. So my rent was also, or my lease was about to expire at my clinic, and it's one of those things of, okay, do you reinvest or what do you do? And talking with my family and my wife, I just really loved the idea of being in academics. So then, kind of thrusting me into the clinic teaching side of things, yeah, again, I had to really kind of stop and evaluate, how do I explain what I'm doing, which I think every clinician should have to do. We kind of do documentation, but not usually to the level that we need. Is okay. Why are you doing what you're doing? What did you see? How does that change what you're going to do with this patient? So being able to communicate that effectively was my goal, right? Whether or not I did that is a whole different story. But yeah, you have to understand, okay, this is my clinical flow. This is why I understand how I treat patients. And working with a young clinician who, usually reacts one of two ways. Number one, they want to learn, they want to get better, or they come in saying, I know everything. And then they're usually going to have an impasse at one time with a patient of going, oh, maybe you don't know everything, and maybe we should reevaluate what we're trying to do. Uh, so it was always interesting to see that journey for a lot of students. Is I think they all ended up coming to the same area. They just came from two different perspectives of either I want to learn, or, well, I'm really good, or I was really good in academics. And clinic is the great uh, the I'm trying to think of the term of it, but it basically puts everybody on an even playing field. Is once you have a real patient in front of you, things start to change, and you have to then know when you need to divert from your thought process. Uh, yeah, so it was another good learning experience for me, and again, it's one of those say yes opportunities of, yeah, teaching in clinic is very different than being in your own clinic. It is a lot more managing kindergartners than it is really clinical work. But when you get those little clinical pearls, it's a whole lot of fun to be able to watch an intern, watch a young doctor actually get to help a patient.
Yeah.
And the hope is that trickles and that snowballs into the amount of patients that they're going to be helping in the future.
Yeah.
So yeah, loved. I really love my time in academia. It comes with challenges. I think if you talk to any professor at any college, there's a whole lot of hoops you got to jump through. There's a lot of regulations, and so it's real easy, I think, for people to point to colleges, especially in our profession, in chiropractic school, everybody thinks their school is the absolute worst. Oh, well, this school is making me do this. And then if you get students in a room together from different colleges, they all start to realize, oh, it's the same experience. Maybe it's not as bad as I think it is.
Yeah.
So there has to be some grace given to people who work at these universities as well, that they have to follow a whole lot of rules and regulations when it comes to what you can and can't do. But just about everybody there wants to be there because they want to help make better students.
Oh, for sure. And I completely agree with the fact of being in clinic right now myself. There's definitely those people where you can see they came in and they're like, I know what I'm doing and I'm ready to go and I'm excited for clinic, which is great. And then like you have the other side of the spectrum where they're like, I'm kind of nervous, not sure if I can handle a patient, but they just need that confident boost. And what's really cool is at least the pod that I'm in currently, it's like we love to help each other out, where it's like if there's a case where like for instance, like I was having a lot of shoulders and low backs and I was feeling pretty confident with all of that, and then I got thrown like an ankle case and I was like, I don't know what to do. But I had a friend who was already experiencing that and he was like, oh, you could just do this, and I was like, oh, perfect. And then that, and vice versa, like he had like a shoulder case and I was like, oh, you can just do this. And it's really cool to see how we're able to like support each other alongside then our CFD kind of like being ahead of us and like saying like, oh yeah, that sounds great.
Yeah, and that's something that I think we then lose once we graduate as well, because the
Mhm.
vast majority of, especially chiropractic students, they're going to leave school and they're going to want to open their own clinic, and then they're on an island. And so we lose that ability. So then what people end up doing is, if they're by themselves, then they almost consider themselves the expert on anything that comes in.
Mm.
Again, as doctors, you have to constantly be learning. So there's this element too, that we have to be okay with saying I don't know. Maybe you don't say that in front of your patient, but internally you say that, right? Of like, okay, I need to learn more about ankles because whether or not you got taught it or maybe it didn't click, it just wasn't ever made real for you. Too many variables I can go into why maybe it didn't stick. But is okay, then if you don't know ankles, who can you talk to about it, or where can you go learn more about this? And so many people view continuing education as a burden versus it's a blessing that we get to consistently learn, and we're forced to by regulations. Uh,
Mhm.
so one of my biggest pet peeves is being on social media forums and somebody asking, "Hey, where can I get these hours I need to finish by the end of this month?" And I haven't done anything this year. I'm going, how have you not taken anything at all?
Yeah.
Uh, there is a difference of like, okay, maybe this didn't go towards my state CEUs, but there's a lot of people in our profession that just don't do any sort of continuing education, even for their own benefit, uh, because chiropractic is such a business element as well. People then always are going to look at the bottom line. Well, is this going to put more dollars in my pocket? You know, is getting better at ankles going to bring you more money? Yes or no, right? We don't know. Maybe getting better ankles, you're going to get a bunch of ankle patients, but you can't necessarily predict that right at that time. Or you can take the view of, I am deficient in this area and I want to learn more. Or I know this is a person who is a relative expert in this area or this thing. Maybe I should learn from them so I can get better and I have the tools necessary for my patients when they come in. And it's also okay not to be a total expert on everything. Know where you're deficient and know when to refer out, or who to refer to. Yeah, in my practice, I pretty much stuck with athletes or active people. Dealing with children was not in my scope of interest at all. So you kind of have two options then. Either A, I can fake it till I make it, is, well, I'll see children. Yeah, because, that's some extra money. Or I knew I had a couple pediatric experts down the road for me, and I would just refer out to them. If I had anybody under the age of probably 10, unless they were insistent that they came to see me because I was already seeing the family, I'd say, hey, here's the name and number of a pediatric expert. That's who I would go to if I were you. And that honestly made life a whole lot easier. Instead of me trying to expand my knowledge in that area, it's just know who already knows this stuff. we don't need to see everybody that walks through our door, but we need to make sure that they are put on the right path to getting better. So, in your experience, you're fortunate that you have all these people surrounding you right now. We're not that fortunate in the real world to have all of that. It really depends on where you are. So, I think that is also a key factor when you're in practice, of knowing what resources you have. And if you're going to be kind of on an island, whether that's because of how you set up your practice, or you're legitimately the only practitioner within 50 miles, make sure you know your limitations and either enhance them or know who to refer to when it comes to those clinical cases.
Yeah. No, that's just such a good thing to acknowledge, is that like we can always be a lifelong learner, but like you don't have to know everything in that moment. Um, and I know you've taken a ton of continuing education. What has been your favorite one so far, or what's a one that you would tell like a new grad they should take?
Oh man. So for somebody who wants to be more into either the sports or rehab world, I kind of say there are three things you need. You need an osseous technique. So, you're probably going to get a whole lot of that in school. If you want to get more into the weeds of certain manipulation styles, great. There's some great courses out there. But make sure you do have the skills for adjusting and manipulations. You also need a soft tissue. And that can get pretty hairy because there's so many different soft tissue techniques. And I think there's a lot of validity to a lot of different ones. Is one inherently better than the other? I can't say that, right? I don't think so. I don't think the evidence really supports it. But the evidence does support the benefit of some sort of soft tissue technique. So whether you want to be hands-on or you want to be instrument, great. Just do something that's going to be helpful, and then have a rehab technique. Understanding how to apply exercise, progress, and regress exercises is fundamental to anybody who wants to be doing rehab in their clinic. So if you can have those three, or I don't want to do rehab, but I want to do soft tissue and adjust, cool. Then know somebody who does rehab. You have to have that resource. So those are the three things I would tell people to focus on. Now, there's a lot of interlinking between the three, and depending on which route you want to go towards, if you want to be a true sports chiropractor and have certifications in that realm, that's going to encompass a whole lot of that. Same for the rehab side, whether you're doing your rehab diplomate or you're doing R2P, that's going to incorporate a whole lot of that as well. So it's okay to kind of divert into one of those pockets, but there's so many different ways to do it. So I'll go ahead and put a disclaimer up as being the president of the American Chiropractic Board of Sports Physicians. I'm going to lean towards that CCSP and diplomate track, because it is a testament to knowledge. In order for you to have those letters behind your name, you have to have passed minimal competency examinations that do incorporate all of those things. Now, what we don't do is say, you need to learn this soft tissue technique, you need to learn this manipulation style. No, it's more generic from the evidence that we do have. And in some of those courses that you would take to sit for your test, it's going to have those things rolled in. So from a holistic perspective, I do think these CCSP and diplomate programs are pretty good at helping guide you towards what you do or don't want to do from a clinical perspective. From my experience, there was a couple of courses that really stuck out. The first one is functional range conditioning. I took that as a very young clinician. That really helped open up my eyes to how soft tissue responds to stress. It's something I don't know if we get a whole lot in if people have a background in exercise physiology or kinesiology. We understand that stress is good. Stress is good for ligaments and tendons and muscle and bones. But how it actually is beneficial is interesting, because when you look at tissues under the microscope, it's a continuum. And the analogy that Dr. Spina always gave in his lectures was, when you get an anatomy model, you take your glue and you put the bones together and you put the muscles together and they stick on, and the tendon attaches to the bone. And that's not reality. it morphs from one tissue to another. So there is not a point in time on a microscope that it turns right from tendon to bone. There's a migration of it where it's maybe 70% tendon, 30% bone, and then it transforms into the opposite as it's attaching. So when we create stress within joints, within tissues, that is actually going to then tell the tissues how to replicate. If you have somebody who has had an ACL tear, and the one of the most common grafts that people are going to have for ACL repair is going to be a patellar tendon or hamstring tendon grafts. So they take the tendon, they'll take out the bad ligament that's inside the knee, and they're going to replace it with tendon. If you come back in 7 years and take that graft back out, it is now turned into a ligament. Now, did anything tell that tendon to turn into a ligament from a physiological perspective? Stress. That's what it did. So by giving a joint good stress, you're actually on the cellular level telling the tissues how to function. You're actually speaking to those tissues to make sure that they are staying nice and healthy. So that's kind of a broad view of FRC, which was really helpful for then understanding how to then rehab soft tissue injuries and how to create good stress within some of those tissues.
Yeah, no, that's so interesting. Yeah.
Yeah,
Oh,
so
sorry.
that's one that's near. Yeah, that's one that's near and dear to my heart is FRC, and there's a whole lot of other things. I think if I had to calculate, I've taken over 1,500 hours of CEs in 10 years. So there's also a bunch that run together that I probably don't remember. So there's so many good things out there. It's just important to know what your tool bag is, and you can kind of create two different mindsets. You can either expand your toolbox or refine your toolbox. If you talk to any construction worker, it's going to depend on the job that they're doing, right? And so you can be a general contractor and have a whole lot of tools, or you can be a subcontractor and also invest into the tools that you already have, because that's what's going to last longer into it. There's no right answer for that, unfortunately, but it's also good, right? There's a whole lot of freedom of find what works for you, find what also stimulates your mind in order to better equip your patients. Is either I need to get better at this or I need to learn more about this thing. And when the two can combine, then it's an incredible experience to then be able to pull something out of your back pocket of going, you know what, I took this course a while back, or I learned from this person, and that has now become relevant to this patient who's right in front of me.
Yeah. No, for sure. I'm super curious about this FRC. So I'm thinking about when people are talking about how they're training, how a lot of the times everyone just thinks about building muscle, but then they end up tearing a tendon or a ligament and stuff like that. Does that play a role into I don't know if that would then just tell for us to build more muscle and then they're lacking in the tissue for the tendon? Is that how that kind of works, is when you're talking about stress, or is that something different?
Slightly different, but that is an important aspect. So from the FRC perspective, the way our soft tissue functions is overall as a joint, it's kind of use it or lose it. So if we don't stress our joints into its full ranges of motion, it's going to be very weak in very specific ranges of motion. There's a lot of lost specificity when it comes to joint function. If I can take my joint through active ranges of motion and stress it on a daily basis, I'm probably then going to have healthy turnover of tissue. If we look at injuries, especially from an athletic perspective, where do most people have their injuries? It's usually going to be in their 10% of elongated position. So a whole lot of eccentric stress that happens into there, or it's going to be at a very intense concentric cycle. That's kind of where we see injuries, which is usually where we're not stressing quite enough. That does play a role into the gym setting as well, but it's really more sport specific. There's a lot of great research, I think, coming out about how we apply load, and there's a really great book that somebody I knew from the Dallas area put out called the I'm going to blank on the name of this book, but it's basically a volleyball training book where she really goes into how we do plyometrics. Plyometrics, I think, is is a misunderstood area when it comes to training athletes. If we think about law specificity, our mind goes to, well, if they do a lot of plyometrics in their sport, they should do a lot of plyometrics in the gym. Now we can actually be overloading. If I'm doing a whole lot of high velocity, am I ever getting to the point of being able to build absolute strength? This is one of the things I'm nerding out about right now is velocity-based training and looking at actually speeds of activities inside the gym itself. And we can look at things from a velocity or strength perspective, and you can meet in the middle of creating high amounts of power. But when it comes to, let's say, a volleyball athlete, what do they do in their sport? There's a lot of jumping, a lot of change of direction that happens. And so if they're in season, how many exposures to high velocity inputs are they getting? Quite a bit, especially if they're doing practice, they're doing games, they've got tournaments, they're getting a whole lot. From the gym perspective, we also have seen a ton of research coming out about how important being in the gym is in season. But if I'm also giving them a whole lot of high velocity impulses in the gym setting, and then they're also getting it at practice, now I can actually be overloading because now the energy systems inside the muscles are going to respond very differently. I don't want to deplete them of energy from doing high velocity in a gym setting and then put them out on the court to where now they're fatigued and then we create injury. So maybe as we transition from off season to in season, we can change the amount of intrinsic versus extrinsic plyometrics and focus more on ground reaction times and creating stability around the joint.
Could you explain what the difference between intrinsic and extrinsic plyometrics are?
Yeah, so extrinsic plyometrics, you can think about your high velocity, low ground force reaction times. So that's going to be your very quick forces. So that is going to be your jumps in basketball and volleyball. That is going to be high explosive activities versus intrinsic is going to be a lot more slower ground reaction times and creating more stability around the joint. So for something like a runner, we want to see ground reaction times probably sitting around 300 milliseconds. So per foot, if we can get sub 300, that's actually going to be more elite. And if you have the availability of very high-tech gait analysis, you can get into this element. But if you just take running as an example, and even at lower velocities of running, we're still trying to do very short time on the foot. In the gym, if I'm in high volume of running outside or on the treadmill, then maybe I want to focus on creating better stiffness into some of those other joints. So now I'm probably going to program things like pogo jumps. And those pogo jumps are actually to reduce the amount of eccentric loading that I'm going to naturally get with faster velocity and reaction times. Without going way too deep into some of the physiology of this, we have reflexes that happen in athletics, right? We'll have an eccentric stretch cycle that takes us into the concentric explosion. Certain joints and certain mechanics don't respond well to eccentric loads. One, for example, is the ankle. The Achilles tendon is probably the strongest tendon pound for pound in the human body. What it's really meant for, and if you look at the way the pinnate muscles of the gastroc and the soleus are formed, it's really meant for explosive concentric focus. But now, if I'm doing a ton of intrinsic forces in my sporting and I'm overloading into eccentric, now I have a lot further to go for that concentric, which is going to overstress the tendon, which in my opinion is probably one of the reasons we're seeing such a high volume of Achilles tears in football. They're doing so many eccentric movements in their gym setting that it's causing overstress to then where they're in a high stress environment such as a game. Now when they put that force into the tendon, it's overloading instead of actually focusing on creating better, stronger, more resilient tendons by some of the strength training we can do and focusing more on absolute and relative strength in those tissues. So that's where I would probably have people focus more on things like isometrics, which you're going to get in certain exercises automatically. We don't necessarily need every football player to go and, all right, get a slant board and start doing isometrics a ton. That's a method of doing it. It's not the method of doing it. And I would also be cautious about overloading them into eccentric isometrics. But we don't necessarily want to create the same stress all the time in those joints. We need to vary the stress. That's been a key thing we've talked about for a long time, is don't do the same things over and over. Well, then we didn't do that in sports, right? If you do a lot of jumping, let's do a lot of jumping in the gym. There's a time to start to increase your volume of jumping, but it doesn't necessarily need to transfer one-to-one from there. Another soapbox of mine, there really is no such thing as a specific exercise other than the thing that you do. The way to be specific on running is to run. We can sit here and we can go over the nuances of certain exercises. And do I prefer my runners to do lunges? A little bit, because I think that puts them in closer positions. But the only way for them to really get better at running is to run. So if they're going to do lunges in the gym, is that so much better than doing a squat? I don't think we can say that. There's multiple ways to do it. Do I want to try and get slightly specific? Yeah, we do. But the problem that we've known for years and we still haven't done anything about is sports specificity at a young age. If there's anything that is highly correlated with more injuries in the youth sports, it is playing one sport. So again, why are we continuing that mindset in the gym when we're working with an athlete, or even in our clinical setting? If I have an athlete, yes, I do want to try to get them to get specific with some of their movements, but that doesn't mean that's the only thing we need to focus on. General strength is also going to work wonders. And that makes things a whole lot more simple. If I can get my athletes to just be strong, they're probably going to be more resilient. And getting your foundations, if you're going to do any sort of rehab, I would highly, highly, highly recommend getting involved with the NSCA. So the National Strength and Conditioning Association. Whether you want your CSCS or not is kind of besides the point. It's about learning the fundamentals of exercise physiology and how your body adapts to specific stressors. That's something I don't think we get as clinicians. We get little pieces here and there, especially in the context of if you're getting them out of an injury state, how do you get them back to what they're doing? But muscles don't respond differently in your clinic versus in the gym. Strength is strength. Hypertrophy is hypertrophy. And the amount of clinicians who still do not understand how to apply appropriate loads, sets, reps, and velocity in their clinics is extremely high. I give a lecture on lower back pain, and that's one of my slides is, okay, if you are trying to create strength around the multifidi, what's your set and rep range for increasing strength? And I get a lot of blank stares.
Yeah.
Or varying opinions. Like, here's the good news. It's actually pretty straightforward and it's pretty simple. What research does kind of tell us when it comes to increasing absolute strength is high intensity loads. That is what leads to more strength. So we want to get people closer to their 1 rep max when we're doing specific exercises. Now, it's how we get there is variable, because if I've got somebody who's injured, they're probably not ready to get close to that 1 repetition. But can I do more load, and can they tolerate that load? If I can get closer and closer to that, then we're going to increase the strength. We also want to make sure that we're keeping that repetition volume fairly low. In fact, there's some really good meta-analyses on your set volume is a lot more important than your repetition volume when it comes to strength, versus the amount of, again, clinicians who do 3x10s is still extremely high. And that's going to push you towards hypertrophy, which they may need. And we can get some overlap between hypertrophy and strength. But if I've got somebody who's injured, probably the very first thing I need to be reestablishing is strength, not hypertrophy, because that's also going to overstress the muscles. Yeah. So learning muscle physiology is fundamental for anybody who wants to be in the rehab setting. Uh, so that's probably where I've learned the vast majority of my rehab techniques now is from being more on the strength and conditioning side of things.
Yeah.
Uh, so again, there's so many great researchers out there that I would push people towards. Too many to list on this, but yeah, if you just follow the NSCA, you're gonna accidentally hit some great researchers within their realm. So when it comes to how do you affect tendons, ligaments, muscles, learn strength and conditioning. That's where we're going to see the most application for how that's going to affect your active patients.
Yeah. I was a personal trainer for a while before I came to chiropractic school. And I remember going through my NASM and it kind of talking about how you want to start your like everyday average person. I know that's a little bit different than your athletes, but like with just like higher repetitions and lower sets just so like they understand the exercise and like
Mm-hmm.
they're not used to it and stuff like that. But like knowing that's also going to be higher volume than just building that absolute strength. I find it really interesting that when you're bringing someone into a rehab setting, and me myself being in clinic right now, I I have to challenge myself when it comes to like I know I need to add load, but sometimes you're like, oh, this is an injury. Like, how much
Mm-hmm.
load should I really be adding? And the fact that the research is saying, like, no, like, we need to be adding load or we need to focus on those like higher sets where we're doing more like 5x5 sort of training is really interesting.
Yeah, and what's also really interesting is, yeah, I think a lot of people too, let's say both from a clinical and from the athlete perspective, is they're also afraid that by doing strength work, they're going to be extremely sore. Uh, we can actually then change that continuum a little bit of, okay, maybe I increase my sets and really decrease my repetitions. So one of the trends I see right now, which I'm very excited about, is for athletes in season, they're actually going to stay lifting heavy weights. The way your muscles will respond to the lower repetition is actually very positive. You're now more maintaining the strength than you are building the strength. There is going to be some relative soreness and slowness that happens when you go extremely heavy. But if I stay at like 90 to 95% of my one rep max and do sets of twos, you're probably not going to be sore. Because you're just stimulating in a way that's making your muscle fibrils contract, and it's making sure it's maintaining those bridges within there. So that's the same for the clinical setting. Is I noticed that when they start doing repetitions of 5 or 6, either they lose their technique or they're getting a lot more sore. Can I just increase my resistance with them and maybe just increase my set repetitions more so than the actual repetitions themselves? Now, in an injury, maybe you can't get that high contractile. So that's where you have to play with it and understand that, okay, if I increase one, maybe I need to decrease the other, and focus on that maximum amount of resistance that I can do with them clinically, and then set my sets and reps, which is why you need to check in with your patients too. Okay, now you can do more, so now we can change this and this. Versus, oh, you're doing good. Okay, just keep up with that exact same thing. That may not be a good approach. If you did that with a personal trainer, right? If somebody came in and says, all right, I want to get bigger, faster, stronger, and you did the exact same exercises, exact same set and repetitions with everybody, and with them, they're going to get better, and then they're going to plateau.
Yeah.
And for some reason, that doesn't make sense to clinicians. That the same exercise over and over is not what's going to be beneficial for your patient. You've got to vary the loads, change how you're approaching it, and then from an injury, you also got to know how to adapt it. That's also, I think, being creative is a good thing of making sure that you can adapt around and with the injury. We always that's one of the cautions we have to give people is we always don't want to be going around the injury. Sometimes we want to go into the injury. Now, that doesn't mean causing a whole lot of pain, which there's a lot of pain science that we could get into about exercising with pain. But how can I stimulate that area of injury in a way that's going to have that positive benefit that we know from muscle physiology versus, well, you're injured, so I want to be very cautious. There's a lot of yellow signals that you can follow, and as soon as you start hitting that higher capacity, you're going to notice that joint pain and that injury is going to change drastically, which changes a whole lot of the pain science as well and how they're going to approach whatever movements that they want to do.
Yeah. When someone is experiencing an injury and you're saying diving into it, are you doing more like isometric holds with them, or is there something different that you're doing typically?
So isometrics are going to be my go-to initially for any sort of tendon issues, or a whole lot of connective tissues, especially when it comes to ligaments. I think that's very valuable for creating some small hypertrophy. But it's going to be very dependent on that person coming in. If that's all we can tolerate is isometrics, great, then that's where we're going to start. If they can tolerate concentric exercise, then I probably want to move them there as well. Excuse me. Again, really depends on where they are in their rehab progressions. So again, initial injury, if they're just coming out of that acute phase, isometrics is probably all they can even tolerate. But as soon as I can get them to tolerate effectively at a higher progression exercise, I want to move them towards that. So there are protocols out there. If you start looking up tendon research, yep, you're going to see isometrics, right? But that is good in that one perspective. So, for example, like I had a patient this week who's dealing with knee osteoarthritis, and he was going to a PT, which in my opinion, I think they were just completely overloading. They were throwing like 15 exercises at him that were all isolation exercises, and he's still in a whole lot of pain. Versus the first thing we did was manage the inflammation, and once we got him out of this loop of inflammation happening in his joint, we started squatting, and he had zero pain with his squats. Cool. Let's do that, because that's going to be a lot more, again, quote unquote, specific to your daily life. Do you want to get in and out of your chair? Yes. All right. We should probably squat then. He wants to stay active. So of course, strength around the legs is going to be a key factor on joint health and longevity. So the sooner I can get him being specific with strength, that's where we're going to see the biggest benefit. We could have done a ton of isometrics in there. That's not what's going to build absolute strength in his legs. If that was all he could tolerate, that's where we start. But he can tolerate a whole lot more. So why not go ahead and progress him on things that are actually going to stimulate more muscle growth than just pure isometrics?
Yeah, it's building that resilience. So let me make sure I got all of this. So if someone comes in with an injury, you basically, summarizing that, making them do the hardest thing that they can do well. If that's isometrics at the time, you do that typically with an acute injury. But if they can do concentrics, do that, because that's going to translate to daily life. Now, if you're dealing with like an athlete and you want to like progress them and make them more resilient, find the things they're not doing in their day-to-day, apply that load that's more strength-based.
Yeah, that's essentially it. And then the other nuance is going to be motor control, right? Which we haven't even gotten into, is when you have an injury, how does your brain change the way you function? Our brains, especially our frontal lobe, does not want us to be in pain. It's going to find ways to change our motor patterns to get us out of pain. So if they've had an injury, whether acute or especially chronic injuries, they're going to have different muscle recruitment patterns. And there's a ton of research that actually shows inflammation changes muscle function. So if we've had an injury, especially with things like back pain, we're going to have the secretion of a lot of cytokines, specifically one that's called tumor necrosing factor alpha. And there was a great research article that I can't recall the researcher's name, but he actually took TNF alpha and injected it directly into the multifidi, and the cross-sectional area of the multifidi shrunk pretty much immediately. Wow. Now, there was another research article that came out last week that highlighted the importance of multifidi cross-sectional area and chronic back pain. So when we see fatty infiltrate of those multifidi, why did that fat take place, right? Fat's not just floating around and finding places to stick in. It's going to replace areas. If we're looking at chronic back pain, that is one of the number one correlations we see asymmetrically in the spine is fatty infiltrated multifidi. If I am learning how to move around my pain or my inflammation, now I'm not getting stimulation to those multifidi muscles, which are going to be the primary driver of stability into the spine. So that's where we also have to take in consideration what's my recruitment pattern, and do I need to then reestablish good stability back into some of those elements? And that's true in all other joints. We see that with the knee, we see that with the hip, but especially the low back. If I'm going to look at the hierarchy of priority, stability over mobility. If I can't be stable, especially in my spine, everything else is going to start to compensate around that. So that's also where you're spot on with the strength aspect, and I want to get them moving. But if they can't move appropriately because they're constantly compensating, that's probably where I'm going to start. Now, the good news, because it's more of a neurological response, that happens very quickly. Usually you can get people neurologically stable within a few days to maybe a week. It doesn't take very long once they get that motor pattern down. And then we can say, okay, now I can go ahead and progress you. What's not helpful is I've had back pain or I've had knee pain and I've learned to work around it. And then I go right into loading and I'm still learning these inappropriate patterns, which is now going to cause inappropriate stress on other joints. So there was an Instagram post that was floating around a few weeks ago that I ended up doing a whole response to because it was bothering me. Is they were talking about osteoarthritis and it's okay to push through pain when it comes to osteoarthritis. I was like, no, it's not, because you're not addressing the root cause of what's actually happening. And while I want them moving, right? The goal is not, well, because you're in pain, you can't do anything. No, but can we be a little bit more surgical in our approach of understanding why they have that joint pain and dysfunction to begin with? Say with this patient I was seeing the past couple of weeks, he's having a lot of pain on one of his knees, but he's had imaging done on both of his knees. And he's like, yeah, I have arthritis in both my knees. I was like, yeah, you do. So why is one painful and the other's not? That has little to do with the arthritis and has more to do with the joint function. That's where we can then change a whole lot, is if we can manage the pain and inflammation. And usually those two things are going to go together when we talk about joint dysfunction. And then I can reset your motor control and I can reset your strength. Then having arthritis is no longer a death sentence. So he came in, basically his surgeon was like, yeah, you're gonna need a knee replacement. He's got 140 degrees of knee flexion and full terminal extension of his knee. I was like, let's not even talk about that. That's probably the last thing you need unless you can't function. But it's amazing, if we change X, Y, and Z, all of a sudden you can function without pain, and now you're moving a whole lot better. Now we can slow down that progression because you're not stimulating inflammation with those movements. So the lack of pain is not the answer. Nor should we be necessarily super afraid of, oh, you felt a little bit of discomfort, we can't do anything. Now, there's a whole lot of nuance to this. I want people feeling discomfort in the terms of exercise is hard. Mm-hmm. So I'm cool with people feeling that. And there can be a slight reaction in the joint within 24 to 48 hours of a little bit of soreness. What we don't want is that sharp shooting pain, or now they can't do their ADLs because we've induced so much pain and inflammation that now they're still creating more compensation, which is going to lead to loading other joints, which is why then we see that cascade of joint irritation. Is, well, I had a knee injury, I went to rehab, and then 2 years later, now my left hip is starting to hurt. Well, now my back is hurting. Well, yeah, because you still never relearned how to function. So we have to take in consideration a lot when you're evaluating a patient, right? Is not only can they tolerate the loads, but can they do it effectively? Because if I can't get them to load effectively, then all of my loading is going to be done inappropriately and in that compensatory manner.
Wow, that was a lot. Yeah.
Yeah.
No, I with the making sure that they're not going into those like the same patterns over and over again. You keep talking about like, we want to decrease the inflammation. We want to lower the inflammation so then we can load those areas. How are you decreasing the inflammation in that person?
Yeah, so that's going to be a two-pronged approach. The first is going to be from some direct anti-inflammatory methods, which for joint inflammation, not systemic, but are direct joint inflammation. A couple things that are really helpful. One is icing, and people have become so anti-ice because of different research things that came out, which I respect and understand and disagree with. So here's why: when we talk about peace and love,
Uh-huh.
that is for certain specific acute injuries. A lot of these people who come into your office, they probably didn't just get injured within the last 24 to 48 hours. If that is the case, then there's a time and place for not utilizing ice, so that way we can let the inflammation happen. Inflammation in short stages is very, very good. The problem, though, is when it persists, and that can happen one of two ways. Either it's chronic inflammation, which is not good, or we keep stimulating inflammation and we go back to acute, 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 acute. That's problematic. And so now we're raising these inflammatory levels in the joint over and over. So ways that actually help with that is cryotherapy. Direct compression, especially on the joint synovium, polarizes macrophages. And macrophages are direct contributors to cytokine production and things like MMPs and aggreganases inside the joint. So we can actually modulate inflammation by cooling down the tissue. We can also do some internal aspects, which can be NSAIDs and medications. Everyone needs to follow their own scope for that and comfort levels, but they're very beneficial for reducing inflammation in the short term. There's also some other research on compression. Compression can also help with synovial irritation, so that's really helpful. So that might be a way for us to get out of a lot of this pain loop that's happening, but we also have to look at the movement dysfunction. When it comes to synovium irritation, that is almost always going to be biomechanical related. So now, chicken or egg, did they change their movement pattern because of pain, or did the movement pattern lead to the irritation? In most cases, I don't know if I can tell you one way or another because they're already coming in pain. Regardless, we can watch them and say, okay, we see these inappropriate movement patterns, or you've had other joints compensate for what's going on. So we need to focus on changing the way that joint is being stressed. So my first line of defense is going to be that 48 to 72 hours of let's do ice, NSAIDs, and some other methods of reducing the irritation. And then let's retrain your joint to move through its appropriate functional ranges of motion. And when we can change those things, that changes the inflammation in the joint itself. That's where the arthritis research has really come in the last 15 years, is that it's not the cartilage itself, because articular cartilage actually has no pain fibers. So people who have joint pain with arthritis, it's not because of the cartilage itself. It's going to be due to the synovium or the fibrocartilage, which is directly correlated with biomechanics. So we have to change that movement pattern for the long-term inflammatory changes. In the short term, there's a whole lot of modalities that we can utilize at our disposal to get them out of that acute pain. Even if they've been in pain for a long time, we can actually reduce the acute inflammation within there. I've had patients actually get mad at me for getting them out of pain with ice.
Oh, wow.
Yeah, I had somebody come in, they're like, I've had back pain for X amount of years. And I was like, hey, why don't we do an icing regimen for the next day? And they came back like, I can't believe my pain's gone. Why, this is ridiculous. I was like, well, I'm happy you're out of pain. Don't be mad at me. I think I did my job, but it can be a very good tool for us to use when it's appropriate, right? So again, that peace and love is for acute injuries. Most of what we're actually going to see is going to be either repeat acute injuries or chronic irritations. And that's where changing the polarization of the macrophages by temperature changes of the tissue is extremely valuable.
Is that why everyone's so obsessed with like the cold plunges and like that making them feel better? Because then they feel like they can do the actual movements they need to do to stress their joints the right way?
No, that has more to do with nervous system
Okay.
priming. So cold plunge is very beneficial in certain settings as well. Now, here's where I would say we don't want to do cold is if I'm in a strength or hypertrophy phase.
Mhm.
Again, a lot of research showing that the cooling of the temperature, because you actually want inflammation in your muscles, post-exercise, that actually slows down mTOR function. And mTOR is a super important enzyme inside of your muscles that helps rebuild the muscles, either increasing those cross bridges or by changing the cross-sectional size of the muscles. So for cold plunge, if I'm doing a cycle of strength, so even for my arthritis patients, I'm using the ice at the beginning of treatment. Once we get past that stage, I actually don't want them icing anymore, because now I'm trying to create either strength or hypertrophy, and that's going to be detrimental in those 12 hours around training. So cold plunge will make you feel a whole lot better. There's a lot of nervous benefits. There's also some of the systemic inflammatory stuff that is beneficial for cold plunge. So there is a time and place for it, and it will make you feel better. Not inherently going to make your joints feel better. It will, because it changes your brain function temporarily. So it'll make your joints feel better. It's not changing the inflammatory phases that's actually happening inside those joints.
Gotcha. Okay. I'm curious because you've worked with a lot of female athletes, and like I don't know exactly what your role is, if they like are experiencing things like PCOS or PMS and stuff like that. But when they're experiencing an injury, do you find that when they're closer to like their like bleeding side, or they just have higher inflammation, that they experience more pain with their injury? Yeah.
Yeah. That is something I don't think I've necessarily experienced. That I will say, I did work an event recently with primarily female athletes, and I guess there's a Gen Z joke that well, first off, they're all singing together. It was incredible that everybody was on their period at the same time. Uh, and yeah, our young athletes, apparently they call it Bluetoothing, because they're all syncing up.
That's hilarious.
So kind of hard to say one way or another, because pain is also very subjective.
Yeah.
There's some good and bad things I've seen with this whole idea of cycle syncing. Um,
Mhm.
I don't know if I can necessarily say one way or another that I either do see it or I don't see it, that they either experience more or less injuries, more or less pain around their cycles. Uh, I think it can change some subjective aspects of it, but I don't necessarily think that the joints are going to be more inflamed if they have an injury at that time. Yeah, I don't know if I've seen that, and I don't know if there's any research for or against that. I think that's a good thing for us to evaluate, which is kind of an issue, is we have not researched this stuff.
Mhm.
What is it? Only like 6% of all athlete research is on females. So the problem is we don't know. And that's why we have to start asking these questions, which I started building into my athlete forums, is asking my female athletes, hey, where are you in your cycle? So we can start tracking those things to see, is there a trend or is there not a trend? Until we ask the question, we're not going to know. And I think too many people aren't asking those questions.
Yeah. It's always like I think this is the good part and the bad part about social media, is like we're able to get that information out there, but you have to be so general about everything. And so when you're looking at this information, look at it as like, this is for me, and how does this apply to me, and what is my actual experience? So the reason why I ask that question is just I've been experiencing like nerve pain, and I've just been dealing with that recently and trying to figure that out. I also have PCOS, and I've noticed this reoccurring pattern of it flaring up typically when I'm around like my bleed or like my luteal phase. And so I was just curious if you had any information on that. But going back to the whole like cycle syncing, or like even cycle syncing workouts or injuries and stuff like that, um I think it's always like you can use that as a like overview of, hey, does this apply to me? How does this apply to me? And it's going to be different for everyone, because like for me, I was an athlete growing up. I was training. I have a little bit more capacity than someone who wasn't an athlete growing up, so my like more restful season of my cycle may look different than someone else's.
Yeah. Yeah, absolutely. And yeah, there has to be the allowing of the individual within this, right? Is I think we're now in this phase of, well, let's group all women together, and everybody who has a menstrual cycle, they're going to experience this, and that is not the case whatsoever. Is everybody's PMS symptoms are very different. And some people, I have seen where some people are actually more performance based around their time of the month versus other athletes, and that has to do with, again, symptoms that they're experiencing. So it's good questions to ask. I just don't think there's enough data for us to make those determinations at this point. But still asking those questions, saying, hey, what are you feeling? And even doing that in a gym setting of taking consideration how somebody is coming into performance training that day is extremely valuable. And that's where some of the wearable technology is helpful. We can overanalyze the data, but it gives us a good picture, right? So if I've had a female athlete who's had a lot of high symptom days in the past 2 or 3 days, maybe they're not ready to do high intensity when they come in. And so maybe I need to back off. The same as somebody who's been at work for 12 hours a day and they haven't slept well and their HRV is poor. That's going to then change how we need to approach our training, more so than the fact that they have a cycle. Again, and until we have some more research that shows one way or another, I think we can over focus on that, and then we're not applying appropriate physiology to how we're going to actually train our female athletes.
Yeah, it's like it's giving yourself the permission to ask yourself, how am I actually feeling today, and not just like pushing through is pretty much it.
Yeah, it's one of the most valid things we actually have in the high performance world is subjective ratings. So asking questions, how's your sleep? How's your mood? How's your soreness? How's your stress? Those are actually some of the more valid athlete questionnaires that we have versus some very specific symptom tracking. That tells us a whole lot more, again, in the grand scheme and looking at acute versus chronic load than, oh, we're at this time of month, so we have to change this training. Now, it goes into the overall self-assessment. How am I feeling? But also not taking one data point and saying, well, I had bad sleep, so therefore my entire week is ruined or my exercise is ruined. No, but if I see a trend of downward, that your sleep is getting poor, now we need to take a step back, and maybe it's not change your training, it's change how you're recovering. That is almost as important as training is how do you allow your body to respond and adapt. If we go into the general adaptation process, we're going to have a decrease in performance. We're going to have a super compensation. All that is going to be dependent on how then you allow the physiology to respond to that stress. And if you add stress on top of stress, now we're causing way too much stress. So we can take those symptoms into consideration. We can take hormones into consideration. We should. Let's ask the questions, but I don't think we need to reinvent the wheel in how we're then approaching our training regimens when it comes to female athletes.
For sure, yeah. Well, I have enjoyed having you on this podcast so much, and I want to respect your time. I just have one last question before we get like all your info on where people can find you. But if there's any tips for any women listening to this podcast right now, how would you tell them to optimize their performance while staying injury free?
Consistency. That is the key for anybody. I think that is something that we don't necessarily see on the female side of things. Is there's too many, and I'm going to be generic here, there's too many influencers saying this is how you lose weight and this is how you build strength. There's a lot of different ways to do it. There's a lot of different goals and progressions and how you're going to get to where you want to be. But staying consistent, whether that's 2 or 3 days a week of doing something, don't let anyone make you feel guilty that you should be doing something 5 days a week, or, well, you're not doing enough. You're not doing enough high intensity. You're not running. There's so many different ways to approach it. It's all valuable and it's all valid. It's just, can we stay consistent with training? From a lot of my female patients and athletes, we just see the yo-yo cycle of they're going to be high adherence for a few weeks, and then they lose it, and then they stop, and then they go back, and then they wonder why their health may not be where they want it to be. And so instead of saying, all right, I got to set a goal for myself of working out 5 days a week, what can you actually attain and fit into your schedule on a regular basis? So if there's anything that really any athlete, but especially I think female athletes can learn, is just be consistent with your training regimen. And by being consistent, that just means showing up and doing something. that's always going to be better than not doing anything at all, or not saying that it has to be a perfect exercise regimen. I will take a bad day in the gym over not going any day.
I love that. Where can people find you?
So people can find me primarily on Instagram at Dr. Blake Graham. From my clinical side, I'm at Delta S Performance. And then people can usually find me at different conferences and symposiums. So I try to attend as much as I can. So I like being around and talking with other people.
Awesome. That will all be linked in the description below. But thank you, Dr. Graham, for being on the podcast.
Yeah, absolutely. Thanks for having me.
Thank you so much for listening to this episode of Becca Babbles podcast. If you enjoyed this episode, the best thing that you can do is leave a 5-star rating and review on Apple Podcast, Spotify, or any other listening platform of your choosing. If you want to learn more about me, you can do that by following me on Instagram at Becca and Wellness, or by checking out my blog, freebies, offers, and newsletter on my website at beccaandwellness.com. If you want to share the love of the podcast, you can do that by taking a screenshot and sharing it on social media and tagging me and the podcast at Becca and Wellness and using the hashtag Becca Babbles Podcast. I hope you have a great rest of your day, and I can't wait to babble with you next time.